of potential metastatic deposits. In stage 1 disease, we do not perform any brain imaging. However, in stage 2 and stage 3 disease, we would do a contrast-enhanced CT brain in patients who are having treatment with curative intent. A contrast-enhanced MRI brain is performed in those patients with stage 3 non-small cell lung cancer patients who are also having treatment with curative intent. So let's start by breaking the TNM classification down, and we start with the T stage. So we have TX, when the tumor is in the sputum or the bronchial washings, but we cannot see anything on imaging. T0, no evidence of tumor, and TIS is carcinoma in situ. So from the imaging point of view, if we cannot see a tumor, basically it would be a T0 or a TX if they have seen it, if they have seen evidence on bronchial washings. And then the T classification is based predominantly on size, but not exclusively. So a T1 tumor measures less than 3 centimeters in maximal dimension. It is surrounded by lung or visceral pleura, but it doesn't involve the main bronchus. And then you've got T1A-MI, T1A less than 1 centimeter, T1B is more than 1 but less than 2 centimeters, T1C is more than 2 but less than or equal to 3 centimeters. So those are all T1 tumors. T2 tumors are larger tumors. They measure more than 3 to less than or equal to 5 centimeters. And there is involvement of the main bronchus without the carina, regardless of the distance from the carina, or invasion of the visceral pleura, or atelectasis or post-obstructive pneumonitis extending to the hilum. So this is either or. So either is based on size or based on involvement of these structures. And there is a T2A and a T2B classification between more than 3 to less than 4 centimeters, and more than 4 centimeters to less than 5 centimeters would be a T2B tumor. We will see images of these, so don't worry too much. T3 tumors measure more than 5 centimeters, but less than or equal to 7 centimeters in greatest dimension. Or else, they are tumors of any size that involve either the chest wall, the pericardium, the phrenic nerve, or satellite nodules in the same lobe. Those are T3, that would be a T3 tumor. So clearly the T3 and T4 are obviously more invasive than the T1 and the T2 tumors. T4 tumors are the most invasive. They measure more than 7 centimeters in greatest dimension, or they could be any tumor with invasion of the mediastinum, the diaphragm, heart, great vessels, the recurrent laryngeal nerve, carina, trachea, esophagus, the spine, or a separate tumor in a different lobe of the ipsilateral lung. So say if the tumor is in the left upper lobe, a separate tumor in the left lower lobe would make that a T4 tumor, irrespective of size. So let's see some pictures. So as we said, the T stage based on the maximal size. When you're measuring tumors, it is important to measure them on the lung window and to exclude any speculations, which could overestimate the actual size of the tumor. Okay, so this was a T1C tumor because it measured more than 2 but less than 3 centimeters in diameter, and it's completely surrounded by lung. So here we have a few more examples. T1 tumor, less than 3 centimeters over here. A T2 endobronchial tumor causing pneumonitis and collapse restricted to the upper lobe. So this is a T2 tumor. And then based on size, a T2A tumor and a T2B tumor on the basis of size, because this measures more than 5 centimeters, but less than 7 centimeters. Again, this is a T3 tumor based on size, more than 7 centimeters. On this image, we can see rib erosion, infiltration of the mediastinal pleura over here in image C, and atelectasis of the entire lung in image D. And there were a few satellite nodules in the same lobe. So these are features of T3 tumors. T4 tumors, more invasive. In image A, it's causing invasion of the pulmonary artery. Image B, there is invasion here of the vertebral body. In image C, this is invasion of the vertebral body here. And in this case, in image D, it's surrounding the SVC, causing its invasion. So those would be features of a T4 tumor. We move on to the N stage, which is the nodal stage. So N1 refers to ipsilateral, peribronchial and/or hilar nodes and intrapulmonary nodes. An N2 tumor involves ipsilateral mediastinal and/or the subcarinal nodes, and N3 tumors involve the contralateral, mediastinal or hilar, and the ipsilateral or contralateral scalene and supraclavicular lymph nodes. Now, when we're deciding whether a node is ipsilateral to the side of the tumor or contralateral, nodes are defined by right versus left-sided nodes according to the lateral wall of the trachea. So if we look at the left lateral wall of the trachea, anything to the left of this line is ipsilateral. Anything to the right of this line is contralateral, for example, in the case of a left tumor. And please remember to always measure the short axis of lymph nodes when you're measuring lymph nodes for staging purposes. So some examples here. There are right upper paratracheal nodes in this patient with a left upper lobe tumor. So these are N3 nodes because they are contralateral to the side of the tumor. So if we draw a line across the lateral left border of the trachea, these nodes are clearly contralateral to the side of the tumor. In arrow B, the tumor now is on the right side. We've got pretracheal lymph nodes here and aortopulmonary lymph nodes. Because the aortopulmonary lymph nodes are on the contralateral side, then by definition, the end staging of this tumor would be an N3. With this case, there is a left lower lobe tumor and there is an ipsilateral mediastinal node, which is to the left of the left border of the trachea. So that is an ipsilateral lymph node. So this is an N2 tumor in a left-sided cancer. A right scalene node, irrespective of whether it is ipsilateral or contralateral, because it is a scalene node, it is by definition an N3 node. Moving on to the M stage. So M1 refers to distant metastasis, and we divide it into M1A, M1B, and M1C subcategories. So with an M1A, the tumor in the contralateral lung, or there is a pleural or a pericardial nodule, or a malignant effusion on cytology. That by definition would make that tumor an M1A stage. And M1B includes a single extrathoracic metastasis, and this includes a single non-regional lymph node. Now, what do we mean by a non-regional lymph node? A non-regional lymph node is an internal thoracic lymph node, a cardiophrenic lymph node, or axillary lymph nodes. All of these are non-regional and they are classified as M1B disease as per the TNM stage. If you have multiple extrathoracic metastases in one or more organs, that would be an M1C stage. And importantly, lymphangitis carcinomatosa does not upstage a lung cancer. So in the TNM classification in the 8th edition, there is no mention of lymphangitis carcinomatosa, though clearly this may change with subsequent editions as our understanding improves. So let's see some pictures. M1A, bilateral or contralateral pulmonary nodules would infer an M1A stage. On these multiple images, in the first image, image A, we can see bilateral pleural effusions. If these were malignant on cytology, then this would be an M1A tumor. Lung metastasis, bilateral lung metastasis in image B is also M1A. Moving on to image C, an adrenal metastasis is an M1B staging, as is a vertebral metastasis. Here you can see a lytic focus within a vertebral body. Also, brain metastasis in the next image, image E, that is also an M1B for staging purposes. And if you have multiple metastasis in one or more organs, that would be an M1C stage-wise. We often use PET-CT if a patient is being considered for curative intent or for radical treatment. And in up to 62% of cases, the TNM staging is altered by the PET-CT scan. So clearly, a more accurate TNM staging can be provided with a PET scan for such patients who are being considered for curative intent or radical treatment. This was a patient who had a right lower lobe malignant tumor with metastasis within the multiple vertebral bodies, as well as bilateral adrenal metastases. So now we're going to move on to some cases. I will give you a brief history, which is the scenario you would have in the 2B Viva examination. Sometimes it is relevant, other times it is not of much help. But then I will show you the imaging and I will scroll for you for each candidate. And then we will go through the findings and discuss the management. So let's start with candidate 1.
Hi.
Hello.
Hi.
Good morning.
Morning.
Okay. Are you ready?
I am, yes.
Perfect. So here is your history. So 77-year-old man who presented to his GP with increasing shortness of breath on exertion, and he has a past medical history of hypertension. So I will bring up the DICOM stack for you. Okay, so we'll start with a chest x-ray for this gentleman. Okay, can you see the chest x-ray?
Yes, I can. Okay, so
Okay, so just tell me what you see.
So frontal chest radiograph of an adult patient. In the left upper zone region, there's a well-defined mass abutting the mediastinum. I can't seem to differentiate it from the descending aortic arch. I can't see any bony involvement. There's no pleural effusions. I can't see any surgical clips in the lungs. So given this appearance, I would compare to any previous radiographs that the patient may have. If they don't have any previous radiographs, then I'll be concerned about this being a potential lung or mediastinal mass. Given that it's a GP patient, I would recommend a CT chest through the 2-week wait pathway and fax my report to the GP.
Perfect. Okay. So there's your CT. We'll start with some axial slices, and I want you to focus on the aorta. I will scroll for you. Okay. So I will scroll through once, and then we will go through it again, focusing on the aorta.
Sure.
And then you can tell me what you see. Okay. So let's go through that again.
Okay, so it's a CT thorax in arterial phase. And corresponding to the mass-like structure that I saw on a chest X-ray, the aorta appears to have a slightly ectatic appearance.
Specifically, which part?
It's the aortic, next to the aortic arch around here. It has this slightly curvilinear structure between the ascending and descending aorta. I'm looking for any calcification or dissection flaps.
Isn't it? Okay, can you see a dissection flap?
I can't see one, no.
No, okay.
No. So in my routine practice, I would have a look at this on coronal and sagittal to further evaluate.
We have a coronal for you. I will scroll through that as well. So it has an unusual configuration, doesn't it?
It has an unusual configuration.
Yes.
It's not aneurysmal. I can't see any penetrating ulcers, dissection flaps, or
Important negative.
Yeah, so I don't it's acute aortic syndrome.
No.
Given that the patient is quite an elderly gentleman, it may represent a slightly ectatic aorta.
So, in conclusion, this would be an abnormality of the aortic arch.
Yeah.
At the junction with the descending thoracic aorta.
Yeah.
The descending thoracic aorta is slightly ectatic, and that is likely due to poststenotic dilatation. Do you know what this condition is called? It's a rare anomaly, but it has a name. Do you think it's a coarctation, or does it look like a coarctation to you, or really?
It doesn't look like a typical coarctation. No.
In fact, it is a pseudo-coarctation.
Right.
It's a congenital anomaly. The important finding is that there's no hemodynamically significant stenosis across this area of kinking or buckling.
Right.
And typically, this happens at the level of the isthmus, which is also the site where coarctations happen most commonly. But in this case, there is no evidence of a collateral circulation. There's no dilated or ectatic intercostals or internal mammary arteries, and there's no rib notching. So the findings would be consistent with a pseudo-coarctation.
Okay.
So, well done. So we did decipher it in the end. We did get to it, and these patients would need further investigation to actually prove that there is an absence of pressure differences between the upper and lower extremities. And we didn't see any rib notching on the chest X-ray. And this variant is important because the treatment for this is entirely conservative. Okay. So we can now move to case 2. Which is here. So candidate 1, are you good to take the next case?
Yeah, sure.
Yeah?
Yeah.
Okay. So this is the history. It's a 76-year-old female. She's brought to A&E after a fall from standing, and she's hypotensive. And they're worried about visceral injury.
Okay.
And we did a CT for this lady. Okay, I'm just going to window it slightly for you. Okay. I'll just scroll through. And then we can go through it again slowly, and you can describe your findings. Do you think you have identified?
Yes. Okay. So CT aortogram. There appears to be an intimal flap which extended from the aortic arch down into the abdominal aorta. So it's a type.
Do you want to look further at the proximal?
Yes, I want to see if it extends to involve the ascending aortic arch.
Yes.
So
So the ascending.
So it involves the ascending and descending aortic arch, and I think I saw it extend up into the carotids. So
brachiocephalic.
Yeah, there. So I can see that's
brachiocephalic and the left common carotid. Yes, that's right.
Yeah, so it's a large dissection flap, and we have the true and false lumen. The false lumen is the one, I think, more lateral. I can't see any pericardial effusions or hematomas. So this is a large dissection flap. I would have a look and to see if it involves any of the abdominal aortic arch branches, such as the celiac or SMA.
Okay, so let's look at those branches. So that's the celiac there.
So I think it does extend. Yep. So the celiac arch is significant.
That's coming up from the true lumen.
Okay. Yep.
And then.
So I'd look at the SMA as well, and also coming up from the true lumen.
Perfect.
Yeah. So they're both coming up from the true lumen. Having a look at the renal arteries.
right? So the right renal artery is here.
Oh, yeah, so that's coming off the true.
The true lumen as well.
Yeah.
What about this?
So the left one coming off the false lumen. So I'll be concerned about hyperperfusion of the left kidney. There is an infarct, I think, a wedge-shaped area of hyperattenuation in the posterior aspect of the kidney. So there is evidence of organ infarction. So
yes.
Yeah, in the kidney.
Perfect.
So this is a large dissection flap involving the whole, basically ascending aortic arch extending up into the brachiocephalic and with left renal hyperperfusion. This is a surgical emergency, and I think it's the Bakey type 3. I would call the vascular surgeons immediately to inform them of this finding. And let the surgical team know.
Good. And the inferior extent of the flap is involving the left common iliac. So that's the end of the dissection flap, and then that's the inferior extent. So it's a very long flap, as you said. Okay. So let's go through the DeBakey and the Stanford classifications. So the DeBakey classification is subdivided into a type 1, type 2, and type 3. And as you said, this was a DeBakey type 3 or a Stanford type A, aortic dissection. So type 1, DeBakey classification, the dissection flap originates in the ascending aorta, propagates at least to the aortic arch, and often goes beyond it distally. Type 2 originates in and is confined to the ascending aorta. And type 3 originates in the descending thoracic aorta, and it extends distally down the aorta. Or rarely, it can go retrograde into the aortic arch and the ascending aorta, as in this case. A Stanford type A involves all the dissections involving the ascending aorta, regardless of the site of origin. So if the ascending aorta is involved, then it's a type A. That's how I remember it. I prefer using the Stanford. I feel it's an easier classification for memory purposes. And the type B are all the other dissections which do not involve the ascending aorta. So you did well with identifying the true lumen and the false lumen. So it's important to identify each lumen and to identify the abdominal vessels which arise from each. As we saw in this case, it was relevant because the accessory left renal artery was arising from the false lumen, and it was causing end organ ischemia, in this case of the left kidney. So the true lumen is surrounded by internal calcifications, the false lumen may contain some thrombus. The false lumen is usually larger and it has a circular configuration. The true lumen is usually smaller, but it's more opacified, as we saw in this case. And the false lumen is less opacified due to delayed enhancement. The true lumen, not always, but usually, is the source, the origin of the celiac trunk, the SMA, and the right renal artery. And the false lumen is usually the origin of the left renal artery. The true lumen is surrounded by the false lumen. The false lumen has a circular configuration. It forms the outer curve of the arch, so it's like in a moon shape, kind of, and it wedges around the true lumen, and this is called the beak sign. And it may contain some remnants of the media due to incompletely detached threads of aortic media, which we call cobwebs. Okay. Shall we go to case 4? Do you want to take this one, candidate 1, as well as your last case?
Yeah, sure.
Okay. So this is your history. 65-year-old lady with cough and anorexia. So keep that in mind. And we will go to the DICOM stack and have a look at her imaging. So we started with a chest x-ray, cough and anorexia.
Okay, so frontal chest radiograph of an adult patient. I can see there's hyperexpansion of both lungs with flattening of the diaphragm, which should be in keeping with emphysematous changes to the lungs. Having a look to see if there's any lung nodules or malignancies. I can't see any nodules. There's no pleural effusion, no pneumothorax. The cardiomediastinal contour has a normal appearance.
If you focus on the lungs, particularly the right lung, do you see any symmetry when that's compared to the left lung? Do you notice anything in particular in the lung parenchyma on the right side?
So there's some loss of markings in the left upper and mid zones. There's in the left lung.
Mid and lower zones in particular?
There's increased shadowing. There's possibly some nodules in the. There's a nodule, I think, in the left lower zone that I can see.
Are you referring to this one?
Yeah.
Okay.
So that looks like there is a large nodule, and I'm not sure. It looks like it's connecting to the vascular structure. It has a pedicle to it. So depending on, she has a history of anorexia, so I'll be concerned about a malignancy. However, given the continuation of the vascular structure, it may also present an AV malformation. So
let's look at her CT. So we did a CT for her. And if you focus on the lungs, just change the window for you. Okay. Have a look. So the chest x-ray wasn't really indicative of anything specific, isn't it?
Mm-hmm.
I'll just scroll through.
Okay.
Have you seen an abnormality in the lungs?
Yeah, so I saw abnormality predominantly. To start off with, it looks like there's a mass in the right apex of the lung.
Let's go back to that.
Here, yeah, right there.
Yes.
So that looks like a concerning spiculated mass, and I'll be concerned about a malignancy with that area. There's no adjacent bony involvement. And going down to the middle lobe, there's also a nodule, I think, in the left upper zone possibly.
There are several nodules in multiple lobes.
Multiple nodes. And then if you go down...
The pattern.
Yeah,
What's
okay.
the pattern?
So having a look... So having a look, I think, down to the middle lobes, there were...
So if you look here, focus on the middle lobe.
Yeah, so there's mild bronchial wall dilatation, and there's some nodularity adjacent to it with bronchial wall thickening.
Can you follow the bronchi to the periphery?
I can, yes. So I'm just trying to see if these nodules are in a certain distribution. The nodules appear to go to the pleural surface, and I'm trying to, which will be in keeping with a perilymphatic distribution with
Can you see any bronchi here within the middle lobe?
I can see them, but I think there's some mucus plugging.
Yes, exactly.
And some tree and bud nodularity. I can also see some bronchial wall dilatation in the right lower lobe.
That's correct, yes.
And I thought I saw some further changes which look slightly infective in the lower lobes here as well.
So in an elderly female, is there anything in particular?
Yeah, so it looks like the changes in the middle lobe, the bronchial wall dilatation, mucus plugging, and possible tree and bud nodularity in an elderly female in a middle lobe would make me think of Lady Windermere syndrome, such as TB, a TB pattern.
Okay. Or Lady Windermere, particularly, which organism is implicated?
It's mucoplasma tuberculosis.
It's a non-tuberculous.
Yeah.
Mycobacterium, which we call Mycobacterium avium or Mycobacterium intracellulare. So together they're called the Mycobacterium avium complex, which encompasses both.
Okay.
So this condition has a predilection for elderly women who typically suppress the cough reflex.
Yeah.
And it's particularly common in elderly women with pre-existing lung disease. In this lady, it was emphysema.
Yeah.
And usually they cough quite a bit and they bring up lots of sputum. But it's a condition, as you said, which involves primarily the middle lobe. And in this case, to a lesser extent, the lingula. And there is also some involvement of the superior segment of the right lower lobe as well.
Yeah. So is the lung mass in the apex, is that a separate pathology, a cancer?
That we are following that up.
Yeah. Okay.
Because of her history of COPD and because of the appearance, it's rather speculated. So she's being worked up for that. On the chest X-ray, if we go back slightly, in the right mid and the lower zone, there are some sort of track opacities because of the mucus plugging and the bronchiectasis in this region. Can you see that?
Yeah.
Sort of tracks radiating from the hilum. And then there's mucus plugging as well. You can get some patchy airspace opacities also. Yeah, that's just about what you can make out on the plain X-ray. Then you would need a CT to further outline what's happening in the mid and the lower zones on the right side. So, yeah, as you said, the differential diagnosis would include TB, and it would include other causes of bronchiectasis as well. But because of the distribution in middle lobe and lingula, that would favor Lady Windermere syndrome or Mycobacterium avium complex infection in the appropriate clinical scenario, in this case, an elderly female with pre-existing lung disease. Okay.
Great, thank you.
You're welcome. Now, let's go to case 5. Just bring up the keynote again. So, let's go to candidate 2 now.
Hello.
Hello. How are you?
I'm good, thank you. Your screen is stuck on the DICOM viewer, though. I don't know if that's just for me.
Thank you. Let me just change that back to my keynotes. Can you see the case 5 now?
Yes, thank you.
Perfect. Okay, so this is a case which I'll show you on the keynotes. It's a patient who had an NG tube inserted, and the clinicians were wondering whether it's safe to use. So the patient had a chest X-ray, and there's a history of oesophageectomy and partial gastrectomy for carcinoma 5 years prior. Okay, so this is a chest X-ray. Whenever you're ready, have a look and let me know what you see.
So this is a frontal radiograph for an adult patient. I can't clearly see the NG tube that's been inserted, but just looking at the lungs, there's no focal consolidation or collapse. There is an abnormality in the sort of right lower zone, which looks like possibly the gastric bubble. This would be in keeping with a previous esophagectomy if it had been pulled up.
Can you see any hyperdense structure there, which would point towards the NG tube? You think you can see something linear and hyperdense? Focusing on this region, can you see something there?
I think, yes, it's coming in and out. I can see that there's a linear structure sort of in that gastric bubble. Yeah.
Okay.
And then going down to there, I can't really see it beyond there.
Okay.
So I presume
it is appropriately placed.
I think it might be too proximal, so it's not appropriately placed. It looks like it's stuck within the sort of post-surgical residual stomach and would need to be advanced further.
That's right. So what would you do in your clinical practice?
I would immediately inform the team that it's not in the correct position and advise that they reassess and try reinsertion.
Good. Okay. So the ideal position for the tip of the NG tube should be in the subdiaphragmatic position, typically overlying the gastric bubble. In this case, it's a bit more challenging because of previous surgery, but it should be at least 10 centimeters beyond the gastroesophageal junction. And complications with NG tube insertions occur in about 1 to 3% of cases, and they are very important to identify. So these are cases where you grab the phone and call the team to remove the NG tube, advise them it's not safe to use and it needs to be reinserted. Okay. So the next case. So this, I'll just bring up my DICOMs for this patient. Okay. So I'll give you the history. Okay. So it's a 59-year-old lady who had previous breast cancer and she presented with pleuritic chest pain. So we did a chest X-ray first, and then we'll take it from there.
Okay, so on this frontal chest radiograph for an adult female patient, there is an abnormality in the left hemithorax with a moderate to large volume left-sided pleural effusion. The right pleural space, I think, looks clear. There's possibly some consolidation or at least basal atelectasis at that right lower zone. And I don't know if this is projectional, but there's possibly also a small nodule in that right lower zone also.
Are you referring to this?
Yeah, just a little bit higher than that.
Mm-hmm. It's quite difficult though, isn't it, to be sure if it's a nodule or if it's part of a consolidation. And what about the left side?
So that left hemidiaphragm, I think, is mostly
see it, right? We can just see the hemidiaphragm faintly. Okay.
Yeah.
But there is something going on within the lung, isn't it?
Yes.
In the left lower zone. Okay. So because of her history, breast CA, we decided to do a CT thorax. So I will scroll through this slowly. So focus on the mediastinum. Okay. And now I will change the window. And we'll look at the lungs. Okay. So I will scroll through it again on lung window now. So focus on the lungs. Okay.
Yeah.
Do you want to describe what you see?
Okay, so in that lateral right lower lobe, there's a almost wedge-shaped area of well-defined consolidation with central, what looks like low density.
Very good.
Corresponding to the abnormality on the chest X-ray in the left hemithorax. I think on reflection, that's more likely due to a grossly enlarged heart rather than an effusion or any consolidation.
Okay, but there are electrostatic bands, yeah, there in the lingula.
There's also evidence of a previous mastectomy.
Great. Is there a name for this appearance which you know of? Is it called anything in particular when you have central ground glass surrounded by thick consolidation? Does anything come to mind?
So I think that's I always get this confused, but is it that's the reverse halo with the ground glass in the middle? So that can be in keeping with an organising pneumonia, perhaps?
So classically, yes. Classically, it's seen in cryptogenic organizing pneumonia, yes. But also we can see it in other conditions such as PE with an infarct, with that appearance, granulomatosis with polyangiitis, which is the new name for Wegener's. You can see it sometimes in TB, sarcoidosis, and in the severely immunocompromised patients, it's suggestive of infection by angioinvasive fungus as well. Very good. So let's go back to the PowerPoint. Okay. So this was a case of cryptogenic organizing pneumonia. Typically, this is seen in patients of a mean age of about 55 years, more common in non-smokers as opposed to smokers. They respond very well to steroid therapy. So usually post-steroid therapy, these areas of consolidation kind of melt away. So they have a good prognosis. On CT, they're often multifocal. The lower lobes are more frequently involved, and the opacities vary from ground glass to consolidation. So you can get the subpleural arcuate opacities and the atoll sign, which is another word for the reverse halo sign. And this is the arcuate appearance, which is being described, which is quite typical for cryptogenic organizing pneumonia. Okay. Are you ready for the next case before we go for a break? We'll go for a 5-minute break after case 7. Are you ready for
Yeah, go ahead.
case 7? Okay. So this is the history. I will show you this on my presentation. So it's a patient with increasing shortness of breath. And we'll go through 6 axial images in lung window from his CT scan. Okay. So I will take you through these images so you can see what you think, focusing on the lung parenchyma. Okay, I'll show you those images again.
Okay, so there's an almost symmetrical bilateral ground glass appearance with more affected changes in the lung bases, with relative sparing of the lung apices, as well as some increased reticular markings, and possibly some mild dilatation of the bronchi, some tractional dilatation of the airways.
What do you feel is the predominant pattern when you look at these lungs?
I think the more predominantly ground glass pacification would be
That's correct.
Yeah.
So what would be your top differential for this patient? Given that
would be an NSIP type pattern.
That's correct. Yes. So this patient has NSIP, and that is precisely because the predominant pattern is ground glass rather than reticulation and honeycombing. There is very little by way of honeycombing. I'm not showing you the extreme lung bases, but there was no honeycombing there. And if you look closely in the periphery, there is some subpleural sparing, which is quite typical of NSIP. It doesn't have to be present, but when you see it, then NSIP should be your top differential.
Okay.
So with NSIP, you see patchy ground glass attenuation or opacification, irregular fine reticular opacities, some scattered micronodules, and honeycombing is inconspicuous or minimal. And as you may know, there are two types of NSIP. There's the cellular NSIP and the fibrotic NSIP. And with fibrotic NSIP, there is some overlap with a UIP pattern. So that's when you may see some honeycombing. But the predominant pattern overall is ground glass. Okay. And consolidation is infrequent. So the typical features are a patient 40 to 50 years old, so a decade younger than IPF. Typically, they present with worsening shortness of breath over several months. It's not associated with smoking. On the spectrum, it tends to be milder than an IPF, UIP type picture. The treatment is with corticosteroids and or cyclosporin, and their prognosis is better. So the cellular NSIP have the best prognosis, and then the fibrotic NSIPs, it depends on the extent of fibrosis. The more fibrosis, the more honeycombing there is, the worse is the prognosis. So it's entirely reliant on the extent of fibrosis, how well they do with corticosteroids or not. So these are some differences between a UIP pattern and an NSIP. So with a UIP, there is an obvious apicobasal gradient. With NSIP, it tends to be more diffuse, although in this case, there was really not much involvement of the upper lobes. A UIP tends to be more heterogeneous, whereas an NSIP tends to have a more homogeneous picture along the lungs. So in this case, the ground glass was quite homogeneous bilaterally from the middle lobe and lingula and downwards involving the lower lobes as well. UIP, there is extensive honeycombing. With NSIP, ground glass opacities are the predominant pattern. With UIP, you get traction bronchiectasis. With NSIP, micronodules are more predominant. Okay, so let's stop for a 5-minute break. Okay, we are back. Candidates 2, are you ready for the next case?
Yep.
Great. Okay. So this is your history. It's a patient referred from rheumatology clinic. Query ILD. Okay, so we will bring up the images for her. And just focus on the lungs. And whenever you're ready, you can tell me what you see. Okay.
Okay, so on this frontal chest radiograph, I think there is an area of abnormal increased reticular markings in the left lung base. The diaphragmatic contour there is also quite irregular. It may be puckered or tented.
It's definitely asymmetrical, isn't it, when you compare it to the right?
I think similar but more subtle changes are also seen in the right lung base, but no, the diaphragmatic contour there is quite regular. The lung apices look normal, just looking around for any focal consolidation or mass lesion. Can't see anything, but that left heart border also looks a bit irregular. I wonder whether there might be some sort of increased area of density in the retrocardiac region, more lateral to the descending thoracic aorta, which is quite ectatic.
What would you do as your next step? What would you recommend?
In a patient in whom they are already querying ILD, I might recommend a CT chest, possibly without contrast, maybe a HRCT.
That's correct. Yes, that's what we did. We did an HRCT for this lady. So I'm going to scroll through. I'll just change the window slightly. I'll change it to a long window. For some reason it's stuck on a bone window. Okay. So I'll scroll through and look at the lungs. And then we'll scroll through again. And you can tell me what you think. Okay. Do you think you have seen the abnormality?
So I can see that there are bilateral cystic areas in a fairly random distribution, but if anything, more along the sort of subpleural surface, but they are randomly scattered throughout all lobes in both lungs. In the lung bases in particular, there's quite a few almost coalescing, like in that inferior lingular, coalescing cystic areas.
Yes, that's correct. And is there a particular distribution? They're more confluent in the lower lobes, isn't it?
Yeah.
Do they spare any areas in particular or not? Do you feel that the entire lower lobes are involved, or is there any sparing of particular areas?
So I think that it's more extensive in the bases, with relative sparing of these superior segments, but there are still some scattered cysts in those superior segments.
So your differential would be that of a cystic lung disease, isn't it?
Yes.
Mhm. Do you think you can narrow that down and see potentially which cystic lung disease you would exclude based on this distribution, given the fact that the lower lobes are quite heavily involved? There's no sparing, isn't it, of the costophrenic angles?
No.
So that almost excludes one of the cystic lung diseases.
So the lower lobe involvement would make me more inclined to exclude LCH, which I thought would be more superior.
Great. Mm-hmm.
Um,
So in a patient who's attending a rheumatology clinic, I will change the window now, and I want you to focus on the mediastinum. Okay. There's a small there's some coronary calcifications.
mm-hmm.
Okay. No lymphadenopathy.
No.
Okay. So this lady had Sjogren's syndrome. She was being followed up in rheumatology clinic for that. Does that help you in defining what cystic lung disease she has? It's quite an unusual.
I was considering whether it might be lamb, but with that you'd expect there to be a chylothorax or something.
And this would be more uniformly distributed, isn't it?
Yes.
Throughout the lungs. So this lady had LIP, lymphocytic interstitial pneumonia,
Right.
which we do see in Sjogren's syndrome. I will show you. Let me revert to the PowerPoint. Okay. So this lady had lymphocytic interstitial pneumonia. So she had a cystic pattern of these thin wall cysts, some centrilobular nodules, some ground glass, but the predominant pattern is cysts, multiple cysts, and some septal and bronchovascular thickening. The differential, as you said, Langerhans cell histiocytosis, but this would spare the costophrenic angles and its upper zone predominant, which was clearly not the case here. LLAM, the cysts are generally uniformly distributed throughout the lungs. So again, this was not the case here. And you can get this appearance with PCP, where you get cystic changes in advanced disease. But that would be in the context of a heavily immunosuppressed patient, as in a patient with AIDS.
Right.
So this was the diagnosis, LIP in a patient with Sjogren's syndrome. And this is very steroid responsive. They do very, very well. So that is the treatment for this condition. Apologies, I was not sharing my keynote. Apologies for that. So if we go back, This was my slide, LIP, cystic pattern predominant, thin wall cysts, central lobular nodules, and ground glass. The differential PCP pneumonia in immunosuppressed patients, where they get cystic changes or nematoceles in advanced disease. LLAM in young females, but there's uniform distribution of the cysts. And LCH, which we've excluded in this scenario because there was involvement of the cardiophrenic angles. And also the distribution was predominantly in the lower lobes as opposed to LCH, which is upper zone predominant. So that was the diagnosis for this case. And these respond very well to steroids. Okay. So if we move on to the next candidate for case 9.
Hello?
Candidate 3, hello.
Yeah.
Okay. I'm just preparing the next case. Okay. So case 9, this is for you. Are you ready?
Yeah.
Perfect. So it's a 79-year-old lady with shortness of breath, dry cough, and pitting edema. All right, so I'll just bring up the images for you. So we'll start with a chest X-ray for this patient. And whenever you're ready, you can let me know what you see.
So this is a frontal X-ray in an adult patient demonstrating abnormality in the right hemithorax, where there is continuous circumferential pleural thickening, loss of volume, airspace opacification, and probably a small effusion. With the diffuse involvement of the pleural thickening, I would be suspicious of an underlying pleural process, such as a mesothelioma or a pleural-based metastases. I would, with this appearance, would move on to a CT to evaluate this further. I don't see any abnormality in the left hemithorax. There is probably some patchy areas with mild, maybe some upper divergence on the left side, but no focal lesions, and potentially slight obscuration of the left postphrenic angle as well, which might suggest some atelectasis or pleural fluid on that side as well.
But we're not really imaging the extreme lung bases. So we can't really comment about a left pleural effusion there. So we would compare to previous chest X-rays, isn't it, or any previous chest imaging?
Sure, yeah. If there is any available, yeah.
And then you'd move on to a CT. I will show you the axials to start with. Okay, so I'm going to scroll through, focus on the lungs. I will go through it on the soft tissue window now. Okay. So focus on the lungs.
Okay, so as suspected on the X-ray, there is diffuse continuous pleural thickening involving the right hemithorax with involvement of the mediastinal pleura, a large amount of pleural effusion, underlying collapse consolidation of the right lung, with the very scarce aerated right lung. So as suspected in my previous X-ray, I would be suspicious of a diffuse pleural involvement, and I would relate any previous history if there's any asbestos exposure or any previous industrial exposure, but this looks like the pleural thickening is suspicious for a malignant process. I think I can probably just see tiny calcifications at the base on the right pleura. And again, I will be thinking along the line of a mesothelioma, and second differential would be a pleural-based metastases, but unlikely just given the one-side involvement and loss of volume with pleural involvement on the right side.
That's a very good description. I will bring up the axial CT again. If we go back to the first slice, first couple of slices, there's a left thyroid lobe, but there's no right thyroid lobe and no isthmus.
Mm-hmm.
Does that help you in narrowing your differential as to the cause of these appearances?
Could it be a previous thyroid malignancy and causing pleural-based metastases, or a...
Perfect.
Yeah.
That's correct, yes. So this lady had metastatic papillary thyroid cancer within the right lobe of her thyroid, which was removed. And then she presented acutely short of breath with pleural metastases. Well done. Let's go back to the presentation. Okay, so in this case, pleural metastasis in a patient with previous metastatic papillary thyroid cancer. So most malignant pleural-based lesions are metastases. They are much more common than malignant mesothelioma. A pleural effusion is the first manifestation usually of malignant infiltration of the pleura. However, in this case, she presented slightly late, so lots of pleural deposits were present within the pleura bilaterally. This commonly occurs with adenocarcinomas, lung, breast, gastric, ovarian, lymphoma, and invasive thymoma. And these deposits, pleural deposits, typically enhance on contrast-enhanced CT. So well done. Are you ready for the next case?
Yeah.
Okay. I'll just prepare your images. Okay, so this is your history. 19-year-old who presented after a seizure, acutely short of breath. clinicians were very, very concerned about him. So whenever you're ready, just describe what you see.
I can't see the ICOM screen. I can only see a presentation.
Apologies. Okay, can you see it now?
I can just see a black screen with like a division in the middle.
Yes, they're loading. Okay. Can you see it now?
Yeah.
Perfect. So take a moment, and when you're ready, just describe what you see.
So this is a,
19-year-old, previously normal chest X-ray.
okay, so this is a frontal chest X-ray in an adult patient. It demonstrates significant abnormality on the right hemithorax with airspace opacification in a perihilar, and also actually extending down to the peripheries, predominantly involving the whole of hemithorax, sparing the right apex, with a more confluent area in the right mid-zone. On the left, again, there is some perihilar opacification involving the left upper and mid-zones. The costophrenic angle on the left side is clear. I don't see any bony abnormalities. The cardiac border is difficult to evaluate due to the opacification on the right side. So in summary, there is bilateral airspace opacification, predominantly in the perihilar locations, more so on the right side with extension down to the peripheries and the base. The APCs are well spared. In a 19-year-old with the first presentation, I would be thinking along if this is an infection or an inflammatory process. And I would, if the patient are quite worried with this, I would proceed to a CT to evaluate the pattern further in terms of what could be causing this high-grade diffuse opacification.
Great. So we did a CT. Focus on the lungs. I will scroll through slowly. And whenever you're ready, just describe.
So again, as seen on the X-ray, there is bilateral ground glass with confluent central lobular opacification in predominantly a perihilar location, more so on the right side, with upper and mid-zone predominance. I don't see any pleural effusions. In a normal practice, I would see the soft tissue windows to check for any lymphadenopathy, but if the patient has come in with an allergic response, I can think of HSP. If the patient is immunocompromised, I'll be thinking long atypical infection such as a PCP.
That's a good differential.
The heart is normal size, so I don't think there is a heart failure or a pulmonary edema sort of a picture.
Great. Okay. So this patient also had hemoptysis.
Oh, in that case, then this can be a pulmonary hemorrhage, alveolar hemorrhage, and because of the diffuse ground glass area, so that could be alveolar hemorrhage on that, which could be diffusely showing as a opacification on the right side.
Great, great. So this patient, he's being investigated actually. He has a vasculitis and he had seizure-induced pulmonary hemorrhage. So during the seizure, he became acutely short of breath, and soon after, he had hemoptysis. So we are still investigating him, but our working diagnosis is seizure-induced pulmonary hemorrhage in a patient with vasculitis. Okay, so on the plain radiograph, very non-specific findings, bilateral airspace consolidation with relative apical sparing on the CT, widespread ground glass opacification. There was a bit of crazy paving as well and lots of consolidation. And then in the subacute phase, which we're not seeing here, you would eventually get fine diffuse nodular densities. And in the later stage, there may also be evidence of interlobular septal thickening because of the intralymphatic accumulation of hemosiderin. So this is our working diagnosis. He's being worked up for a vasculitis of some sort, likely a small vessel vasculitis. And the associations are with Wegener's or granulomatosis with polyangiitis, other connective tissue disorders, SLE, good posture syndrome, and pulmonary hemosiderosis. So the differential diagnosis of this appearance, as you rightly said, are pulmonary edema and diffuse pneumonia. But in this case, the heart was normal in size. There were no pleural effusions, no fluid in the fissures. So when he had hemoptysis, this was put down then to pulmonary hemorrhage. Now I have a second case, which is somewhat related, also in a 19-year-old, another 19-year-old. Do you want to take this one as well?
Yeah.
Yes? Great. Okay, so this chap presented, also first presentation, he had never been to hospital before. He presented with shortness of breath and right-sided crackles, ulnar auscultation. And I'll bring up his imaging. So we'll start with his chest X-ray. Okay, so whenever you're ready, have a look.
Again, I can't see the DICOM. I think it's still in the PowerPoint. Oh, that's okay.
Apologies, sorry. Okay, can you see it now?
No, I can still see the PowerPoint.
You should be able to see it
Yeah,
now.
no, I can see it now.
Great, okay. So have a look, and whenever you're ready.
So this is a frontal chest X-ray in an adult patient demonstrating large, like this cardiomegaly with generalized enlargement of the heart. There is airspace opacification involving the right hemithorax, predominantly in the lower and the mid zones this time. The claustrophrenic angles, I can just sort of make it on both sides. The left hemithorax is otherwise clear. So in summary, there is cardiomegaly with airspace opacification involving the right side in the predominantly mid and lower zone pattern. The apices are again clear with no bony involvement.
Mm-hmm. So what would you do?
On a 19-year-old, having this large heart is quite rare, abnormal. Yeah. So I would be thinking if he has got any previous congenital, like a septal defect or something, which has given that enlarged heart appearance or something like that. If I would relate with any clinical history in the background, just to check for any septal defects. However, the opacification on the right side is still odd, and this would need evaluation with the CT further to suggest what it could be.
Okay.
Sorry, your voice is actually disrupting.
Okay, can you hear me now?
Yeah, I can hear you now, yeah.
Okay. And can you see my screen?
Yeah.
Okay. So this was his CT. I'm going to scroll through and look at the heart and the lungs for this patient. Okay. I will go through it again.
Yeah. Okay. So there is again generalized cardiomegaly. There is a small right pleural effusion, significant ground glass coalescing changes in both bases, involving the bases and the right middle lobe. I think there is evidence of pulmonary plethora with enlargement of the hilar and enlarged arteries with some pruning very peripherally and some pacification in the apices as well. I mean, again, going by the same theme as you initially suggested, a ground glass opacification bilaterally in both bases in a young chap, I would be worried if there's some sort of a pulmonary hemorrhage that's causing it. I mean, pulmonary edema would be in my differential because of the large heart as well.
Cardiomegaly, yeah.
And there is also some effusion on the right side, so it could all be related to a cardiogenic cause with pulmonary edema and effusion. Can't really think of anything else in my differentials.
I will change the window.
Sorry, your voice got cut there again, so I couldn't really understand what.
I'm going to change the window now. Can you hear me?
Yeah, I can hear you now.
Okay, I'm going to show you the hearts. So I'm changing to mediastinal window. And you will see that the heart, as you said, is significantly enlarged. And there's a pericardial effusion as well.
Yeah.
Together with the pleural effusion and the lung changes you mentioned. So this patient had an echo and he was found to have a decreased ejection fraction of less than 40%. Don't forget, he's a 19-year-old.
Mm-hmm.
This was dilated cardiomyopathy.
All right, okay.
In a patient who presented with pulmonary edema.
Sure.
So the diagnosis was made on echo and on CMR. Subsequently, he had another CT, which I'm going to show you. And on this, pleural effusion has resolved. There's no fluid in the fissures. There's no edema. The heart is enlarged, obviously, but there are no residual lung changes after treatment. So that was the diagnosis for this chap.
Thank you.
And now he's being followed up by cardiology. So dilated cardiomyopathy and pulmonary edema. Dilated cardiomyopathy is defined as a left ventricular chamber dilatation and decreased systolic function with an ejection fraction of less than 40% in the absence of coronary artery disease or conditions which impose a chronic pressure overload. And there may also be RV dysfunction. And the causes are related to intrinsic myocardial damage. So we make the diagnosis by echo and on CMR. There are many causes. So it could be ischemic in the presence of coronary artery disease, ischemic cardiomyopathy, could be infectious, post myocarditis, could be due to an infiltrative disease of the myocardium, sarcoid, amyloid, metabolic, toxic, alcohol misuse, cocaine, secondary to chemotherapy. Doxorubicin in particular is implicated. A couple of others like peripartum, patients with muscular dystrophies, autoimmune cross-reactivity, Chagas disease can get a late onset cardiomyopathy as a sequela of that. This case was idiopathic dilated cardiomyopathy, and it could also be familial, so there could be a genetic element to it as well. And on cardiac MRI, we would see that the left heart is markedly dilated and thinned. There's mid-wall enhancement on late gadolinium sequence, which is consistent with fibrosis. And these patients have a higher risk of sudden death and arrhythmias because of this scar tissue. Okay. Let's move on to case 11, which will be your last case. Okay.
Yeah.
So okay, are you ready for this next case?
Yeah.
Case 11. This is your history. 34-year-old lady with previous cardiac and renal transplants.
Yeah.
Let's bring up her imaging. We'll start with her chest X-ray. I will window it a little bit for you.
Again, I think you have to change the
Yes.
screen back complete.
I'm going to share it now. Yeah. I was just windowing it a little bit. Okay, can you see it?
Yeah.
Just X-ray now. Okay, great. Whenever you're ready, have a look and go for it whenever you're ready. 34-year-old lady with previous cardiac and renal transplants.
Okay, so this is a chest X-ray in an adult patient, which demonstrates diffuse abnormality of both lungs. There is perihilar ground glass opacification involving both hemithoraces. There's no loss of volume. The costophenic angles are slightly obscured. However, no frank pleural effusion. The heart size cannot be really assessed on an AP window. Don't see any bony involvement. There are a few lines. I think it's is it an NG tube, which is I can only see projected at the level of the distal esophagus, which needs to be which needs to be pushed down further to the stomach, and there is a central line which is projecting over the. Actually, is going down to the stomach? Yeah, I can see it now. So
No, this is an ECG clip.
Fine, yeah, so yeah, so it is definitely needs to go.
It
Yeah,
is
it's isn't it? And the central line is in the correct position. So with the history, I will be thinking along the lines of a infection, an infectious process, and the transplant history. I would like to know about the immuno status of the patient, if there is evidence of immunosuppression findings.
Yes, she is heavily immunosuppressed, yes.
So with that history, my first differential would be a PCP, which is known as PJP now in the current context, and I will do a CT to evaluate the pattern further.
Well done. Let's have a look. She's now intubated.
Okay, so
We'll go back up and scroll again.
yeah, so the AT tube is in correct position. There's diffuse abnormality of both lungs with confluent ground glass opacification, probably some interseptal thickening giving a degree of crazy paving, more dense consolidation in the bases. There is a bronchograms throughout both lungs. Again, with the pattern, PCP will be upper med differentials for this. This picture can also be presented as an ARDS with the patient intubated and acutely septic with a gradient and consolidation in the bases.
That's great. That's great. So there is a gradient, isn't it, in this region? So there's ground glass with consolidations in the more dependent areas. So this lady had PCP pneumonia causing ARDS. This has a very high mortality. In fact, she passed away 10 days after the scan. I'll bring up the coronals for you just so that you can further just change the window. For some odd reason, it seems to be going back to the bone window. Okay, so these are the coronal images, which again nicely show that gradient, so predominant pattern of ground glass in the upper and mid zones, and more consolidations, extensive bronchograms in the lower zones. And by this time, they had correctly replaced her. Great, well done. You had quite hard cases, I have to say. But you did really well.
Thank you.
Let's go back to the presentation. So this was PCP pneumonia causing ARDS. So in these patients, there's a severe pulmonary insult, in this case, viral infection in an immunosuppressed lady, causing diffuse alveolar damage heterogeneously throughout the lungs. The etiology can be pulmonary, or it can be a response to a systemic injury. In this case, it's a response to a viral infection. Mortality is very, very high, around 50%. And the survivors, many of them develop chronic lung disease because the way damaged lung heals is by fibrosis. Minority make a full recovery. So ARDS has a similar clinical presentation and the histological features of those which we see in an acute interstitial pneumonitis, which is basically diffuse alveolar damage histologically. So both conditions, they likely represent the same pathology, with acute interstitial pneumonitis probably accounting for some of the idiopathic causes of ARDS. On CT, in the early phase, which we saw in this lady, pulmonary opacification, there was an anterior-posterior density gradient within the lung with dense consolidation in the most dependent regions. The ground glass opacification, which we saw in the non-dependent regions, those reflect an overall reduction in the air content of the affected lung. And in the acute or early phase, likely represent edema and protein leaking within the interstitial and the alveolar spaces. There's bronchial dilatation within the areas of ground glass, and you can get pulmonary cysts in the early phase. And then in the late phase, or those who actually survive this, you can get either complete resolution in some cases, but in most of the cases, they would get a coarse reticular pattern and ground glass opacification in the non-dependent part of the lungs, which is considered to be more typical in the late stage. They get areas of reticular and ground glass opacification, and they can get pulmonary cysts, likely because of their prolonged ventilation. So this is a very severe insult to the lung with a high mortality. So quite poor prognosis there with a mortality of about 50%. Okay, so let's move on to the next candidate. Candidate 4. Okay. I'm going to unmute you now.
Hello?
Hello. Hi. Hi.
Sorry. Hi.
Okay. So, shall we go to case 12?
Yep.
Yep. So, this is your history. 48-year-old lady with atypical chest pain and palpitations. Rule out coronary artery disease. So in this case, we're going to focus on the coronaries. I'll bring up the images for you. Okay.
Yeah.
So have a look, focus on the coronaries, and then I will scroll again and you can start to describe what you see. She's 48. Okay, so that's the right coronary terminating as a PDA.
Yeah.
So that's the dominant vessel. If we go back and follow it, follow the right coronary from its origin, and tell me what you think.
It's got. I'm worried that there's a
So this is
malignant.
the right coronary, isn't it?
Yeah, I'm worried that there's a malignant course, so there's a transarterial course of the right coronary artery between the aorta and
Yes.
so it's transversing laterally. So this is a kind of malignant course. So I would call the referring doctor and alert them to this because this is associated with sudden cardiac death.
Yes, well done. So the right coronary artery is arising from the left coronary cusp or sinus of Valsalva there. And then it's coursing, as you said, between the ascending aorta and the pulmonary trunk. So that's a malignant course. And it can get easily compressed. So you can imagine there's a very small space there. And it can be easily compressed, which can lead to arrhythmias and sudden death. Left main stem is arising normally from the left coronary cusp as well. So that's the LAD. And that is the, other way. That's the left circumflex. There was no evidence of calcified plaques throughout. In this case, since the right coronary is dominant, it supplies the PDA in the base of the heart. It is even more important, this interarterial course. Okay, well done.
Thank you.
Let's go through that. Okay, so this is the interarterial course of the RCA, where the RCA has an aberrant origin from the left coronary sinus. It courses between the ascending aorta and the pulmonary trunk. It's quite uncommon, thankfully. But there's a potential risk of ischemia, arrhythmias, myocardial infarction, and sudden death. And you can have an interarterial course of the left coronary artery as well, when the left main or the LAD or so coronary anomalies are quite rare. They present in 1% of the population. They can present rather late as well. This lady was 48. Sudden cardiac death is usually related to exercise in more than half of patients. And this is the second most common cause of sudden cardiac death in cardiac athletes after HOCM or hypertrophic cardiomyopathy. The risk for sudden cardiac death depends on how the RCA actually originates from the left coronary sinus. So its angulation, its orifice, whether it's slit-like or not, whether it has an intramural course, or if it's dominant, as in this case. There are other anatomical variants as well, but these are not malignant courses, prepulmonic, transseptal, or retrocardiac, but these have no hemodynamic consequences, so they require no treatment. And the treatment for a malignant course would be surgical unroofing, coronary implantation, or a cabbage. These are the options for the malignant variants. And the patients do very well with early treatment. Okay. Let's move on to case 13 before we go off for a 5-minute break again.
Okay.
All right.
Yep.
So this is your history, 62-year-old with shortness of breath after a myocardial infarct. And I'll show you the chest x-ray for this patient.
Okay, so I'm presented with a frontal chest radiograph of a patient presenting with shortness of breath post-MI. There is calcification within the left ventricle, well, projected over in the region of the left ventricular wall. In this context, concerned that this may represent an aneurysm. I'm just looking at the remainder of the chest radiograph for features of left ventricular impairment. There are no pleural effusions, maybe some impression of slight upper lobe blood diversion, but no frank alveolar edema at this stage. I can't assess with the image quality that I'm currently getting for interstitial lines. But,
I agree with that.
Yeah.
Well done.
So I would want to further evaluate with in this context with contrast enhanced CT.
So I'm just going to give you one slide. This is not my case.
Okay.
You've got the answer there. Your description was appropriate. The only thing I would comment about is that when you first started presenting the chest X-ray, you said in a patient with post-MI, dyspnea post-MI, that showed me, if I was an examiner, it would show me that you actually listened to the history. So that's good. Because sometimes in the heat of the 2B viva, you may forget the history and you might have a crucial clue there, which will narrow your differential quite significantly. So I quite like that you repeated the history because you felt that it was relevant to this case. So there is extensive pericardial calcification, as you can see. It's outlined by the arrows. And there's some compression and deformity of the free wall of the right ventricle there. So what do you think? Does that help you in any way? Look at the right ventricle. The right ventricular chamber is very, very compressed.
So I think the main job that I would need to do is ascertain whether it's a true or a false aneurysm, and the fact that there's extrinsic compression may mean that there's like hematoma within the wall that is causing that extrinsic compression. So that is clinically significant.
Definitely, yes.
I'm now scratching my brain to make sure I say the right.
So usually with calcified aneurysms, they would calcify in the long term.
Yes, true. Yeah.
So this patient presented shortly after his MI with these extensive calcifications. And given the deformity of the right ventricular wall.
Yeah, and it's circumferential rather than, yeah, okay.
It's not focal like you would expect an aneurysm. This was constrictive pericarditis. This patient had right-sided heart failure, presented with shortness of breath, and he had diastolic dysfunction on echo. So one of the causes of constrictive pericarditis is post-myocardial infarction, could also be post-radiation, post-surgical, post-infectious, post-traumatic, could be idiopathic as well. Most of them are actually idiopathic. They're presumed to be viral. And this can also happen post coronary artery bypass grafting as well. So the key to this diagnosis, as opposed to an aneurysm, is the short history, and also the fact that it's causing molding of the wall of the RV, compression of the wall of the RV. Usually an aneurysm is outpouching,
okay,
rather than an indentation. So echo and MRI are your best imaging modalities to diagnose this, but on CT, we should raise a suspicion if we see pericardial thickening and calcification, and especially if we see deformity compressing the right ventricular chamber. On MRI, there is an early diastolic septal bounce, which we see accentuated during early inspiration on free breathing on the Cine sequence. And this is almost diagnostic, and it helps us to distinguish from the other differential, which is a restrictive cardiomyopathy, where this septal bounce is absent. The differential includes cardiac tamponade, but these patients present with impaired cardiac output and the raised JVP and the muffled heart sound, all of that, which wasn't present in this case. Another differential is pericarditis as well, without constriction. So just one slide about cardiac tamponade. This happens when there's a large accumulation of fluid within the pericardial sac. Fluid can be anything, can be hemorrhage, can be due to an inflammatory process, or can just be a simple effusion. Basically, in these patients, they get collapse of the right ventricular free wall in early diastole, and the right atrial free wall in late diastole and early systole. And there's severe compression of the cardiac chambers, together with a dilated IVC and SVC. So this is a very compressive picture, compressing the cardiac chambers. So the management of a constrictive pericarditis is by surgical stripping of the pericardium. But in most patients, especially if it's post-MI, post-infectious, they're given a trial of anti-inflammatory therapy, NSAIDs, steroids, and colchicine to see if it improves at all. Otherwise, they would go to surgical stripping as well, but this is quite a difficult process. That's my understanding.